member is our members are Dr. Mallikarjunaswamy, Dr. Mahesh Prasad, and Dr. Vishal Kundnani. So I will ask our Dr. Chaddha sir to deliver President message on behalf of IOA President Dr. Atul Srivastava. Sir.
Good evening, everybody. On behalf of the Indian Orthopaedic Association and on behalf of our President, Dr. Atul Srivastava, I welcome you all for this IOA webinar from the Spine Subcommittee. It's a very interesting topic where we are trying to get two subspecialties together, which is orthopedics and arthroplasty. And basically, these are the two common things done by all general orthopedic surgeons as well who don't belong to the subspecialty. Like lumbar canal stenosis is probably the commonest surgery done by a general orthopod. And TKR is probably one of the commonest surgeries done by an orthopod as well. So these two are large procedures which are done by the magnitude of people all over our country. And the majority are orthopedic surgeons. So it's very interesting to now weigh that if you have a patient, all of whom are growing old, including my colleagues here and myself, tomorrow if we have equally symptomatic low back and knees, which one should we address first? And would it be the patient who decides? Would it be the doctors who decide? Or would it be the symptoms and signs that decide? So this is an interesting topic, and it would be something where we would all put our minds together. And I am happy to be here on behalf of the IOA to participate in this event. Thank you for inviting us.
So this year's IOA President theme is Stronger Bones, Stronger Nation. And now I am straightway to the topic. May I ask Dr. Chaddha sir to deliver his speech.
Thank you very much. May I share screen? Coexisting spinal stenosis and knee osteoarthrosis, what to do? Well, about 25 years back, when I started seeing both low back and knee issues coexisting, and at that time, I had just moved from being a pure orthopedic surgeon, doing trauma, doing pelviacetabular, and doing joint replacements, to a spine surgeon. I was a little bit confused. Why is it that if a car stops running, especially a rally car, what should we look for? Should we look for a problem in the engine, or should we change the tires? I thought I was a little bit biased because I felt I'm a spine surgeon and every time it's the engine that needs to be looked at. And over 25, 30 years, I've realized that the answer is somewhere in between. It's neither my answer, not your answer, but somewhere in between. Hence today, when we see a large number of people, and I'm now touching 60, so in a couple of years, I'll reach a stage where I'll have to decide between TKR or lumbar decompression for myself. And what is it that will decide the way forward? Well, I am very convinced about two things. One, that after LASIK surgery for the eye, which is the most patient gratifying procedure, probably the second most patient gratifying procedure in the world today, elective, is total knee replacement. Why is that so? Because it makes unhappy people very happy for a long period of time. Let's say at 60, I get my knees replaced. I have good quality of life till I'm 80. So this is something which is really a paradigm shift in quality of life. And there's a quantum leap in the way we live. Unfortunately, low back surgery, lumbar decompression, makes unhappy people less unhappy for some time. So as it is, the spine surgeons are actually fighting a losing battle, and it's my duty to try and fight back as the underdog. I have always believed that when patients come to us, they could be in acute, exacerbated pain, unable to bear any pain, and the x-rays may look like the ones to the left. While you may have patients who are walking around, hobbling around, with x-rays to the right, and they seem to be living with it. Somewhere in between, we have to find an answer. And I think the answer is that we need to treat the man and not the scan. Is it so only with the knee? No. The MRI to the left looks hardly surgical, while the MRI to the right says, operate on me tonight. Yet, the clinical symptomatology may differ. The demands and health-related quality of life issues in patients may differ. The decision is more important than the incision, and hence it's very important to start with why. Why are we offering surgery for low back, or why are we offering surgery for the knee? The purpose is more important than the process or the product. It's much later that you decide whether I'm doing a lumbar decompression, open, minimally invasive, with implants, without implants. Same way, whether I'm replacing the knee, whether I'm doing cruciate sacrificing, or I'm keeping the cruciate there, whether I'm doing a uni, whether I'm doing whatever, all poly, that's left to you guys. That decision comes much later. The decision is that surgery really indicated? Hence, the three important steps in taking such a decision are counseling, counseling, and counseling, so that we get a right fit as far as which patient needs what. This is probably the most important part of our discussion today. All of us, as we grow old and if we live long enough, will need some overhauling of the lower back and the knees. But when to do what has to be a shared decision between the surgeon and his team on one side and the patient and the caregivers on the other. In our country, we don't deal directly with the patient because the patient is patient plus family, and we as surgeons are surgeons plus team. There are a lot of articles available, and a few of them I shall quote. One, what should we operate? The knee or the spine first? Interestingly, if you compare the number of knee replacements and the spinal decompression fusions done, 2.5 times number of knee replacements happen as compared to low back surgeries. But then we have twice the number of knees. We have 2 knees and we have 1 low back. So it's not unusual that the knees are outnumbering the lower backs. A study was done by this same group, which gave the option, studied and took feedbacks from patients to find out whether they would choose for a spine surgery or a total knee replacement. And what they came out with was that shared decision making is extremely important. When the knee and the lumbar spine are equally symptomatic, we have to go beyond and push the envelope to find out which of the two is really affecting quality of life and to what extent. Finally, such patients who have purely degenerative, they don't have something like a spondyloarthropathy or an inflammatory disease. That means they don't have ankylosing spondylitis, they don't have rheumatoid arthritis, they have standard OA. In this, if the spine is more affected, you go with the spine first. But if the knee is affected by an inflammatory disease, is a valgus, or has major gait issues, then you address correcting that deformity first before addressing the spine. Having said that, there are various papers that have come out, and there's one from our own country, which has even tried to give you an algorithm. The algorithm tells us that you have to actually go with the patient in mind first. Why is that so? Because in our country, there are very limited studies where you're actually looking at pelvic indices, spinopelvic balance, and such things, because these are not really adhered to by the masses. Hence, concurrent problems are addressed mainly with the patient in mind first, provided that both are purely degenerative, the lumbar spine as well as the knee. However, if it is an inflammatory disease with greater deformities, the one with the deformity is addressed first, and this case usually is the knee. There are certain confounders like the hip also being involved. And it is a point which we have to look at, that we have to look at the patient as a holistic human being. So if you have situations where the spine, the hips, and the knees are all involved, you may have to actually weigh one against the other and take a decision whether the rear tires or the front tires need to be changed first, or whether the engine needs to be serviced first. Symptomatology will always be important in the knee, hip, spine syndrome. Hence, you have to listen to the patient silently. Decisions are not made on scans, radiological imaging. We have to look at the symptoms and how their quality of life is being affected. All our answers have to be less objective, more subjective, very personal and individualized. Everybody does not fit into a fixed size. Everybody has different needs. If there's somebody who's mainly homebound and does not need to walk more than 15 to 20 minutes, but has deformed knees, get the deformed knees sorted out first. But if somebody by choice has to walk, they are uncontrolled diabetics, then get their spine sorted out first so that you can improve their capacity and their stamina to walk. So these are individual decisions. The other thing, which I always believe, spend a lot of time in your clinic counseling them. You should not admit them and then counsel them. No, it has to end before the admission. You cannot have counseling starting on admission, whether it's for a knee replacement or whether it's for spine. It's all to be done preoperatively, counseled, even consented, and then brought in. Despite all this, you will have three types of patients, whether it's for the knee or for the spine. There are some who are very acquisitive. They will always be unhappy. Then there are those who are contributive, who are happy, but they still want more. And finally, you will have a large number who are happy whatever you do for them. And with the knee, be extremely careful. Majority of them do very, very well. Still stick to the rule and execute and perform the surgery with precision. Always find your checklist and always have a purpose, proper planning, proper process, and precision, whether it's the spine or the hip. Always answer these questions. Is surgery the only option? Can I make him or her less unhappy? Is the risk-benefit ratio in favor of the patient? If it's the spine, do they need decompression? Do they need fusion? Do they need deformity correction? Or do they need a replacement? Or is this patient an outlier? A lot of our patients in the low back are outliers. They have functional overlay. And we've seen so many of these mental issues cropping up post-COVID. Always remember, the happiest patient is the one who buys the surgery rather than the one to whom you're selling a spine or a knee surgery. Always work with a team and work with a partner who will give you suggestions and stop you when you're going wrong, whether it's in counseling or whether it's in execution of the surgery. Have a low power distance index. Someone who may be 5 years younger, even 10 years younger, that can stop you and help you take a decision correctly rather than you make the mistake and you go back. Hence, always work on the 4Ps, the purpose, the planning, the precision, and finally get in and do your surgery. The final decision is always of the patient. Keep the hubris in your head away and bend down and bow below the heart or in front of the heart of the patient. Use the URL. Unplug your head, relax your hands. Don't be in a hurry to operate them. They are all elective surgeries. And listen to the heart of the patient. The heart should rule the head and dictate the hands. Always plan with the surgeon and the patient. The patient is first and not the surgeon. Thank you very, very much for a patient hearing.
Thank you, Ram sir, for the wonderful discussion. So now may I request Dr. Indrajit Sardar to deliver his lecture on today's topic, coexisting spinal stenosis with osteoarthritis. Indrajit sir.
Okay, can you see the screen?
Yes, sir. No, this is a take-home message.
We're starting with the take-home message.
Welcome, Navin sir. Just now, our Secretary General, Dr. Navin Thakkar sir, has joined.
Just a minute, I'm adjusting. There was some issue of updating the Zoom, so I've updated just now the Zoom.
Yeah. Now share.
Yes, sir.
Oh, I can't seem to get back to the
First slide.
Yeah, the first slide.
The home, I think in your laptop home.
So left side top right, you have to cross and start.
Just go back again, close everything. And
No, escape first, escape. Just
escape, just come out. Just come out first.
Escape. He wants to go to the first slide, né?
Yeah.
So you have to escape and again select the first slide and start from the beginning.
Okay.
Escape it, just. No, PowerPoint escape, sir. PowerPoint. Just click on that slide.
Not moving.
No, click on that slide itself. Where is the PowerPoint program here?
At the bottom, taskbar. In the taskbar, come to PowerPoint.
But there is no PowerPoint.
Yeah, there it is. There it is. Yeah.
Yeah. Click that, sir.
That, and then escape.
Now.
Set top
Now
left, red one.
I think I can go out of this first.
Yes, go out of that. No problem. You open up again, sir.
Yeah.
Yes. IOA Sunday.
Yeah.
Go to the first slide. Yeah, and now make it complete. Yeah, sir.
Okay. So TTR and spinal stenosis, and the first thing which may seem elementary to the number of spinal surgeons, but it's very easy for us to see the ergonomic body posture. And we have to look at the poor posture, the good postures and all. And the main thing is that in the advent of an aging society, we're living longer. The abnormal posture with the body balance disorders is a serious issue, because this is leading to decline in activities of daily living and health-related quality of life. I think we are all, the spinal surgeons are of course conversant with that of the cone of economy, which refers to the upright body posture, maintained by the skeletal muscle strength of the body, and involves everything, right from the foot and the pelvic circles and the bigger ones which goes above. And all of this is the cone in which a person moves and retains balance and a good posture. So the balance efforts and the center of equilibrium dimensions are found to be significantly greater in degenerative lumbar-spinal pathologies. And patients with degenerative lumbar-spinal pathologies presented with lower levels of activity. So even if you have a knee problem with that added to the degenerative lumbar-spinal pathology, which is presenting with lower levels of activity, you have a double whammy. So this is the posture which we all know. And the investigations to detect spinal problems is well known to all of us, but not so well known to the arthroplasty surgeons, that we need to take x-rays of the lumbosacral spine, the AP and side bending and lateral and extension, and of course now the sitting and standing position X-rays to judge the pelvic obliquity, which will determine the hip positioning of how much anteversion to give and how much not. The MRI, of course, we're not great experts at that, and sometimes a CT scan and a 3D reconstruction. In most clinical symptoms are restricted to the knee alone. That's the one they come to us with. But in 10 to 15% are simultaneous knee and spine symptoms, which Ram has already talked about so beautifully. Sometimes the spine symptoms are intermittent and not so important as we judge them and after talking with the patient. And in other, spine symptoms are dominant and knee not so, and without significant deformities, but pain. So in these cases, when both are equivalent, is the real problem. With significant radiological findings on both sides. And here I must say that we always refer to the spinal surgeon for his opinion first. He opines first where the spine should be operated first by all his methods of X-rays, MRIs, blocks, all sorts of procedures which they use. And then they recommend to us that, okay, the spine needs to be done first, and we leave that decision to him. That saves us a lot of trouble later on. If we look at the clinical tests that we have to do for the knee and all that, we above looking for the polyarthritis and the pain deformity, etc. On the back pain, since we are not that much a spine people, we do the back pain, we look at the radiation, which is very important for us. Intermittent claudication, neurogenic or vascular. We look at the back muscle spasm, bony tenderness, sacroiliac or paraspinal tenderness, and bladder bowel signs. And deficits of neurological or vascular, the SLR persistently there and the lassitude test, etc., which we learned about. But the main thing is that we determine at that particular point whether the spine is a simple one or a complicated one, and what is the issues arising from the spine, which we can detect and which we need desperately the spinal surgeon to look at it and tell us as to how to proceed on that. The knee spine syndrome, there's knee hip syndrome, knee hip spine syndrome and all that. And this measures the simultaneous changes in knee flexion and sacral inclination, as you can see in these figures. So as the knee flexes, the sacral inclination will 5 degrees less when the knee flexion group. And when the knee flexes, you get increased patellofemoral pressure, you get patellofemoral plane. And of course, with that amount there, then when you do the knee, ultimately, the correction of the flexion deformity is a problem when the patient stands. And you have patients with these spinal sacral inclinations who have gross knee contractures. And even if you correct it on the table, the moment he starts walking, it tends to recur and it gets very difficult to correct that flexion contraction. So if you look at the standing and the sitting of the sacrospinal, you look at the sacral slope that changes between standing and sitting. And that is a great issue in pelvic inclinations. And that is a great issue in when you're doing your hip placements. The knee also, you have to look carefully at what is there in the hip always. And judging by the previous things that we always do, look at the plantar above, etc. The whole thing is that if there is a hip problem and a knee problem, we tend to do the hip first. Is knee arthritis linked to spinal stenosis? You bet it is. Patients with pre-existing lumbar spinal stenosis have lower functional outcomes at the TK. And if you look at the severe lumbosacral stenosis has reduction in the AP diameter of the thecal sac and increased morphological grading. And this correlated with a significant reduction in preoperative ROM that was not improved after open radius. So persistent postoperative reductions in the range of motion after recovery from the training contribute to reduced patient satisfaction and recovery. And that is one of the reasons why almost, they said 20%, some said less than that, 15% or 10%, but there is patient dissatisfaction. So these are familiar to the spinal surgeons. I won't go into that, but there is grade 0, 1, 2, and 3, and the severe ones as individual nerves are compressed in severe crowding and compression. The severity and location of the lumbar spine stenosis affects outcome of the rehabilitation. And that is a fact of life which we have some have learned it the hard way, and now we tend always to look at the spine, always, before doing any investment. So we have to tell patients that they can expect relief of arthritic symptoms following TKR, but they may continue to experience limitations in post-operative function relative to their expectations. And of course, which Ram quoted this paper, the multi-center study, which showed that the lumbar spinal stenosis is at a problem after arthroplasty. Concurrent degenerative knee and lumbar spine disorders and the type and severity of the knee deformity, and that was Kundnani's paper, which Ram made my talk easier by quoting it beautifully. And as he said, the severe valgus deformity and windswept deformity, where the knee is obviously at a problem, there's obvious deformities, and that will have to be tackled first. But if there is absence of deformity of the knee or mild deformity, then the spine surgery first. And we had this survey in which the spinal surgeons and the joint replacement surgeons, and they both had identical features. So preoperative TKA could be a benefit for the properly corrected sagittal spinopelvic alignment by spinal fusion. Therefore, preoperative TKA should be considered as a surgical option for patients with severe sagittal spinopelvic parameters in concurrent and degenerative ASD. But this is only for short level fusions less than 3 segments. The algorithm in that, what we follow is a radicular symptoms of spinal pathology should be treated first. In cases of predominant back pain, which could be either due to loss of lumbar lordosis or precipitated deformity by malalignment to osteoarthritis, knee replacement is considered first. But whatever we do, a close relationship with the spinal surgeons, and we talk over each and every case with them before he or we touch the patient. And as Ram said, of course, the patient. Of course, always the patient and the family. So this was a 57-year-old Jenny Valgas. This is the spine, had definite spinal symptoms. This was treated with a short segment fusion by the spinal surgeon. And this was a result, which usually is such a satisfying operation that you get. This is not an uncommon situation at all. In the case 2 of mild spinal symptoms, no radiculopathy, no deficits, X-ray has mild lumbar spondylosis, no question at all, go for the knee. And this we did a CR 150, as Ram so correctly pointed out, that what you do is different, but you make your decision which part you're tackling first. And then the spine operated, this was a long segment fixation with a knee pain of 10 to 70 degrees ROM. And this was, we did this, this thing, though she had a good, I couldn't get her knee thing, she was walking well. But what happens is that her range of motion improved only to 90 degrees. And we had counseled her from before that. So that was what she accepted quite easily and was happy about it because she could walk. Now, most of these patients, even these ladies, they want to go out. And one of their things is traveling. And most of them want to travel to quite some distances. In fact, all of our patients that we have seen with this problem, they travel. And the first thing is that, can I travel? Can I go by this train? Can I go by bus? So they are quite walkers that way. So the take-home message basically in total knee replacement, always consider the spine. And we cannot do anything without considering the spine or the spinal surgeons. Of course, we have to examine clinically and listen to the symptoms. As again, Ram had pointed out, listen. Everything, all the things they say, they can come out equally, that what are the things that are aggravating their pain and what are they thinking about. do investigations, and if we as arthroplasty surgeons find anything significant in the spine, we will refer it. We will refer it anyway, but we'll do it with gusto. We counsel the patient that with spinal problems, the results may be compromised as regards motion range and pain relief. And again, this counseling, as Ram mentioned in a triple way, that this counseling and this sort of information has to be given to the patient who has spinal problems with knee problems. Sometimes the TKR first may relieve the back pain as we showed, but cross knee deformity has to be tackled first. Thank you.
Thank you, sir. Thank you for this detailed discussion. And now, I, on behalf of Spine Subcommittee of IOA, I must thank our President, sir, and our Secretary for giving us this opportunity. And now, may I ask Dr. Navin Thakkar to say a few words. Okay, I think Navin is not in. So now, may I request Dr. Kanchan Bhattacharya to say a few, to highlight some points for today's topic, that is the coexisting spinal stenosis and osteoarthritis, what to do.
So as part of the panel discussion, I'm not sure how this goes on, but I think I can just sum up what Dr. Ram Chaddha and Dr. Indrajit Sardar has just said. And I think we are all cognizant of the fact that we have to treat the patient first. We do know that a large number of the knee patients come out very well, but our experience and the literature says about a quarter to a fifth of them are not very happy. And many of them are not very happy, not because of a surgical disaster, but because of the other factors which have already been mentioned by both the speakers. We chose the wrong patient. We chose the wrong, that we had a wrong diagnosis regarding what should have been done first. And we did not meet with the patient's expectations. Taking these premises, I think it has been very aptly described that we need to decide which has to be dealt with first. And this topic here is a little easier than differentiating between a spinal osteoarthritis with stenotic syndrome with hip arthrosis. Since it is knee, my take is more like what Indrajit said. All my knee patients who have had any amount of back issues go to the spine surgeon, and I operate them only after they get a complete okay from the spine surgeon. And we try as hard as possible to counsel the patient, tone down the expectations, especially with coexisting spinal issues. When it is spinal issues and an inflammatory issue for the knees, things become a little more difficult because the results may not be as good as that. And that, I think, is my take on what the two speakers have said. And I completely agree with what has been said. Thank you.
Thank you, sir. Thank you for your input. Now, may I request Navin Thakkar to say a few words.
Welcome to all the faculty and the delegates on behalf of Indian Orthopaedic Association. Thanks to all the faculty for a great contribution, academic contribution, to share, contribute, and learn together. And we'll be sharing, learning, and contributing together. And the committee is working very hard to spread the knowledge about this, all the pathologies of the spine. Thank you very much. You can go ahead with the academic program, sir. Thank you.
Thank you, sir. Thank you for
Thank you,
giving
sir.
us this opportunity. So now may I request Dr. Rajiv Chatterjee to say his opinion regarding today's topic.
I think it's been very well articulated already. Just two things I can add basically. Rather than just symptoms alone, I actually dig for the spinal symptom because quite often these are elderly people. They are unable to differentiate between the leg pain and the knee pain and the leg pain. So somebody comes to me with even very bad knees, I specifically would go and ask them about leg pain, ask them to show, is it the calf or the knee or both? So if calf pain or leg pain going down, again, as Kanchanda, everybody said, refer to spinal surgeon first and then take them. Second point, I think extra that I do is when I'm looking at the knee, it is also a thorough spine examination I will do. So I dig for the spinal pathology before I decide on the knee. I just make sure that I haven't missed it. So otherwise, you have a very unhappy patient. Lastly, I think the other problem that I face is a bad varus knee, which we have corrected, and basically bilateral varus knees, when we come to a normal valgus, they tend to start getting a bit of radicular pains just post-op, which settles down with time. Even the spine is normal before. Is this something that we all face because we have corrected the one varus and the other is still varus because of limb length discrepancy and a bit of spinal stress happening? Is there any way out on these? That's my question to the other panelists.
Can I say?
Yep.
Yes, recently, just before 1 year, I got one example case of my pediatrician. His mother-in-law has been operated for the spine and the knee replacement, both has been done. The knee surgeon did the knee replacement, spine surgeon did the lumbar canal stenosis treatment. Still, she was not improving. And both they were going one pillar to other pillar. Somebody said the knee has a problem. Somebody said the spine has still the problem, or it's a recurrence, all that. When I examined and saw that, we should not forget hip. I could find AVN in that patient. And once the hip replacement we did, she became fine.
Absolutely.
So hip also should not be forgotten, because many times all these conditions are going together and we are not knowing exactly which is the source of the pain and what is the quantum of the source of how many percentage is due to spine, how many percentage is due to knee, or how many percentage due to hip pathology. So that is the example of the doctor, pediatrician's mother. So this is also to be looked after.
Yeah, I think Ram was discussing one thing before we started off, and that was simple. And he said, don't just concentrate on the spine and hip or spine and knee. Concentrate on the spine, hip, and knee.
Yes.
That is not an unusual situation. And as we found out, this happens. So in that case, I would really open I would start a discussion amongst the panel. How do you tackle it? Will you do the spine first and then the hip, then the knee? Or which way would you go about it? And is there anything you will add to this situations?
Before starting the discussion, I just want to say a few words, if you allow me. Sir, can you hear me?
Okay, please.
Just a very important example given by Dr. Navin Thakkar, that there may be coexisting hip pathology as well, but during taking history, it is very important. That
yes.
What's the radiation of the pain and what kind of pain? Anterior thigh pain is usually from a hip pathology. Hip pathology is a common culprit behind anterior thigh pain, and usually that pain doesn't go beyond knee. So if the patient complains of predominantly anterior thigh pain, the hips must be checked. And one thing I must highlight here, that most of the patients with knee osteoarthritis comes with only after 55 or 60, and as this is a degenerative process, so there may be coexisting degenerative changes in other areas also, just like spine, what we are discussing. But the main problem is that if it is a spinal stenosis without a gross listhesis or something, clinically you may not find much you may not have much findings. It's just not like knees that you are getting the MJL tenderness, getting obvious deformities. But in case of spinal stenosis, you may not have much findings unless they have some neurology, some deficit. And it is not very common in spinal stenosis. So what is more important, I think, that is the patient should be asked how far he or she can walk. That is very important. And even with knee pain, patient can manage to walk for a longer distance. Yes, I have knee pain, but I can manage. I can walk for, say, even for 1 kilometer, even more than that. But for stenosis, the main point is that even with stenosis, I cannot walk for a certain after certain distance. That is the main point, should be asked in the history. So that will guide you that to think about the spine, because it is not possible for each and every patient to do a MRI scan for the spine. We can maximum do as X-ray, that is feasible. But even with X-ray, we can see some spondylotic changes, but that may not be conclusive of a spinal stenosis. In that case, MRI is needed. But to be a cost-effective, the history is very important, that how far that patient can walk. That can give us a guide. And another very important thing, what Dr. Chaddha sir has told, that we should concentrate on man, not on the scan. Very well said, because I can give you one example. That is, that a patient, if she cannot say have come to your clinic and cannot walk more than say 500 meters, but at the same time, that is symptomatic, and you can smell that it is there is maybe some underlying spinal stenosis causing to neurogenic claudication. But at the same time, patient has severe knee pain, may not be very much varus, or there may not be very fixed flexion deformity. And if this type of patient usually comes to us, that what to do first? Do the spine first or the knees first? If we think that the patient cannot walk 500 meters, definitely the spine should be addressed first. But if this patient, say, is a housewife and she doesn't need to walk more than 500 meters, her most activities are confined in the home. So in that case, even for walking for 10-15 minutes, she doesn't have pain, for neurogenic pain, only the knee pain. In that case, I feel that knee should be addressed first, and patient may not need a spinal surgery even for her activities, unless there is some deficit. In that case, we can do the knees first with counseling, that you have the spine pathology, spine pathology. It might need a second surgery if it affects your activities of daily living. Otherwise, we can treat that part conservatively.
Can I just butt in here? Am I
Yes.
allowed?
Yes.
This is where, Saikat, you and me work together. How many of you see, I send them out, because if you have calf pain, these are elderly people, they're unable to differentiate the exact site of pain. You specifically have to ask them about calf pain while walking. If they have calf pain while walking, it is a spinal pathology. It's
Yes.
causing problem. And you have an unhappy patient. Because with knee replacement, see, this is what, as Ram also said, in a spine, they are trying to get from a very bad situation to a bad situation and a reasonable situation. With knees, the demands are much more. They want from bad to a completely pain-free situation. And that is where very, very imperative, you have to ask for the history of pain or butt claudication. Two things they ask, and specifically radically. These things you have to dig, because otherwise the patients will not give it to you. They're confused. They said, we have leg pain. What is the leg? The whole leg. Then you ask them, do you get pain while walking in the calf? If they say that, I think an MRI at least to be done, so that you know you're not dealing with a lumbar canal which is just building up. You do the knee, and then you correct the varus. You stretch the nerve out. They come back to you with more problems. I think that's where I would still push to make you work harder, and then I do the work later on.
Yes, yes, sir. Just one thing to add, that regarding the symptoms, along with calf pain, I always ask for, is there any tingling kind of things or not? Because tingling especially occurs in case of neurocompression. Tingling doesn't come for knees, at least. And we did a retrospective study, not from our Manipal patients, also from my other side patients also. and presented in last SSWA con, and we found that up to, it is a small number group of patients, only 32 patients. In 10% of cases, it was found after the knee replacement has been done that they have coexisting spinal pathology as well. That was not detected before the knee replacement was done. So it is in 10%. Maybe literature may say more than that. Actually, right now we are more aware than before. Probably that is the reason.
Can I add?
Yes,
Sure, sir.
Yes. So what you said is right perfectly, but we are also seeing the patients where the knee replacement is done, and there is also a diabetic, some neuropathy, and that also mimics sometimes. So what is the problem is in the high volume centers where the operating surgeons are different and the screening surgeons are different. So they get labeled that it is made for the replacement. It is made for the canal stenosis. So what we do is, when we suspect the spine pathology, there is a standing instruction to our MR people that always screen the hip. And when we stand for the hip, we always screen the spine, so that we do not miss anything. That is what we are doing in our practice.
I have a question, sir. So clinically, if the patient doesn't complain of any groin pain, if we do not elicit any anterior hip point tenderness, if the patient can squat and sit cross-legged, still you ask for a hip X-ray?
No, not for that. But there are multiple pains and multiple complaints, and old age patients, they said that we are not squatting and sitting cross-legged since very long. So don't ask us to test for that. We'll not be able to do that. So at that time, only the screening can only help us.
I just add one
I
point.
think another, just a second. One of the other things that happens is the vascular ones. And vascular, I don't mean the arteries only, but the veins. Most of these patients have leg swellings, varicose veins, etc. It gives us awful sort of heaviness, and which also gives a sort of a blotting paper feeling to your plantar surface. And that is a very confusing thing also regarding whether it's coming from the spine, from the vessels, from the veins, artery. That's another issue which also has to be looked. And another issue is that we always tell whoever the residents or whatever it is, look at the dorsalis pedis artery, look at the veins.
Can I just add one point here? I think it's become quite standard for us to do a scanogram film in our knee replacement patients, because we usually want to compare pre and post-op. A scanogram film picks up a hip pathology anyway. Yes. 95% of patients have a scanogram film, because I want to follow them up, make sure I've corrected them. So that picks up a hip pathology, very low cost way of dealing with it. And as again, Indra said, clinical examination, dig for the symptoms, think that there's something else before going for knee replacement, and then do your knee replacement. You will get the best patient. Can I share 2 minutes? Can I just share a personal experience which I've had last week? A relative of mine has been seen and counseled multiple areas, different cities in the country. Big shot. He's just wanted my opinion whether he's going to have a robotic knee replacement or normal knee replacement. Luckily, that day, as I was walking to my chamber, he came out of his car, and I was just accompanying his distant relative. Look at the gate. He had a foot drop grade. Nobody has seen the foot drop. Today, he has had an MRI done. He's got a lesion in his L4, L5, which is possibly metastasis. Today, this is today's hot news. So I'm saying that it's so important to observe gait. And there's a problem with high volumes. I don't like the term high volume center. We are doctors. We are there to help our patients. This is not a business opportunity. So even at high volume centers, you have to treat your patient as you do for your MBBS final year exam. This is what I tell all my DNB residents. Please, even now at my age, I write my thing as if I am giving my MS exam. We write the, we have a long case, just shorten it a bit, and that's the way mine is written. That saves my trouble later on, my patient's trouble later on. So that's where I think high volume centers also possibly have to get more doctors in to get those things written down and examined properly to miss a problem.
Right.
To the all moderator and panelists, is it recommended to do masked MRI for each and every TKR and THR patient? Do you recommend it?
I would say so, not a mass MRI. It would all depend on the clinical findings and the presence or absence of the knee and hip symptoms. If that is much less than what the patient is complaining about, I will do an MRI. But if there is no symptoms as such in the spine, or the symptoms are intermittent, that goes away often, I would not recommend a mass MRI for every patient. Only in those whom I get an impression that he needs to be investigated for the spine.
So may I interject here, and I'll just sort of swing the goalpost a little bit, that if you're looking at the word mass, what I would want to do mass in the elderly as far as knee replacement or hip replacement or spine is a bone density.
EMD. Agreed.
Please do that. We're not looking at short term, we're looking at long term quality of life, and correcting that is an integral part of spine, hip, and knee surgery.
Well said, sir.
The overall architectural thing.
Absolutely. It's very important, sir. In fact, if I have two patients, both needing surgery for hip, knee, and spine, and if the bone density is low, I would go with the replacement first rather than a stabilization of the spine if spine needs to be stabilized. And if I have to actually do the spine, I try and do least or no metal in the spine, because the chance of implant cutting out in the spine is much higher, because we have to get a bony purchase with a screw versus a replacement of a joint. So it's actually which works against us. So as I look at it, and a lot of my patients whom I correct their bone density over a period of time, they become good friends because I don't need to operate on them. They can tolerate their back issues.
Right.
Can I just interject one? Again, in the knee group, because I'm more of a replacement person. So when I examine the patient along with the joint line, I run my finger around the tibia shin. If the patient complains that tibia shin is more painful, I would definitely have a very low index to get this investigated, treated, because they quite often some osteoporotic pain which is causing more pain. And I agree with you completely there. I've got caught out where I've done a knee replacement, persistent pain, realized the bones were so soft. In fact, a couple of them had collapses. The implant collapsed down. So not even like the instrument, you said the instrument's cutting out. Even a replacement can collapse down.
It is a soil test before making a building.
Exactly. So the soil test is you run your finger along the tibial shin. If the patient winces more than the knee joint, something going on there. You can have a stress fracture, post-osteoporotic, so common. Because all of them are tibia vara. The stress fracture building up. So these things we have to sort of catch before we go in. Otherwise, we can be caught out.
So you would rather give them an anabolic before the surgery rather than try to protect the surgery later.
Yeah, right. For the surgery and then go in. Because you go in, when you're doing the cuts, it has happened to the cuts. You put the tibia plate in, the tibia plate just sinks down in front of your eyes. It's happened to me. Once or twice. It's really troublesome to your heart. The heart doesn't take too well after that.
In a large number of retrospective study, it is seen that replacement patient with concomitant back pain result in worse functional outcome. Why?
So could you repeat the question?
What he says that they are more unhappy patients, those who are having a back problem and knee problem, and they are replaced. They are more unhappy for the replacement itself, or not happy that much. That was what your finding is.
Yes, sir.
That's why counseling is so important.
Yes, sir. In 2013, there is a JBGS large cohort study, and they said that psychological counseling is very much important before putting knife in spine as well as hip and knee.
That's the problem with knee. As again, Chaddha said, in spine, they expect the pain will come down a bit, they'll be able to walk. With knee, they want to run. That is a big problem. So you need to get their end points sorted out, saying that, look here, we're doing this, you're going to walk like this, not better than that. You have other problems also. Be prepared for that. Spend time with your patients before.
So there is a one terminology for that. that the surgeon should prevent oculobrachial reflexes.
So we have with us Dr. Ananda Kishore Pal.
Before holding the knife, they have to think oculobrachial reflex. That is common with the surgeons. Anytime we see the fracture, immediately we think which implant, what to do, how to do. But before that, we have to investigate completely.
Whenever you see something, take a step back, take a deep breath, think.
Yeah.
That's your mother in front of you or a father in front of you.
Yes. So that is the oculobrachial reflex. It is the science where we have to unlearn this, because we are used to, if you see the new residents, they will talk about what they will do fixation. Before asking anything, they will say, I will put a nail or I will put an implant. They will not say, I will need a CT scan or something like that. That is the teaching now going on. So we have to unlearn this.
Okay, Mallikarjunaswamy sir, please.
Yeah, thank you for allowing me to speak.
Yes, just Dr. Pal, I'm Dr. Pal. Just I want to highlight one point. Basically, yes, sometimes patient has come with some pain in the knee, or the patient may complain of just reduction of the space, reduction of the walking ability. That is that man. That in that case, that is very difficult to differentiate whether it is coming from the spine problem or due to knee problem. Whether both the knee and the spine shows a radiologically positive. So in that case, what I do in my practice is suppose there is a grade 4 osteoarthritis, and similarly there is some severe lumbosacral spondylosis and maybe MRI positive of spinal stenosis with radiation pain. So everything has been discussed. That is the knee pain is localized. Basically, it is related with some movement. Specifically, it is related with some initial part of the movement. It complained of pain much more. But whether it's the spinal stenosis, patient may complain of pain after some time. It's heaviness, basically tingling, numbness, or patient there is maybe walking with a little bit forward leaning posture. So that may be the ideal situation, whether we can easily differentiate whether it is coming from spine or knee. But basically, how to differentiate which one should be done fast? That is what in my practice, what I do. I actually inject several in the grade 4 osteoarthritis is going to become total knee replacement. I inject some steroid or local anesthetic in the knee and have to check whether the pain is subsided. Now give some physiotherapy and whether the patient is a little bit relieved or not. Still, the patient is complaining of pain during walking. Heaviness, everything. That means it is coming from the spine. And now I refer the case to the spine surgeon for spinal stability. Otherwise, we go for the knee first. So that is my technique. Another sometimes the knob block can be done for the spinal stenosis also. That can relieve pain a little bit. And now we can check whether it is coming from mainly the knee problem is the main disability or not. So in this way, I can differentiate and choose whether which one should be the ideal operation of choice in the initial mode. Okay.
I think it should be reverse. So spinal injection should be first, not the injection in the knee. Not injection in the knee. Better to go give a spinal foraminal block or something like, and then they check.
Yeah, that is a reverse. That is if it is a symptoms is more, then I can do the spinal injection first. That depends on the complaints of the patient. That is why the clinical.
If you are thinking of replacement, don't put the steroid in the joint.
So that is the last one, because I've already told you it is a grade 4 osteoarthritis, so there is no harm to give some. There are several other long-term steroids that already come, so they doesn't cause any problem. And if we make a little bit of time interval between the injection and the total knee replacement, that will not cause any harm. So that is why we can do that.
So Dr. Mallikarjunaswamy wanted to speak.
Yeah. Thank you for allowing me to speak, and I'm happy joining the scholars today. Of course, as already our colleagues have mentioned, there is no substitute for good history taking and clinical examination. When I examine the spine, of course, most of the time our lumbar canal stenosis is diagnosed with history, not with a clinical examination.
Left and right.
When I examine the spine, other than the spinal canal stenosis, one should not forget thorough examine the spine. Sometimes these people will have claudication simple with myelopathic changes. When you are on cervical level or in the cord level, one should not miss out that. And we should have careful history taking of any early signs of bowel and bladder, early signs of going for like red flag signs in the spines, like early deficit and foot drop, early signs, and SA joint one should not forget, and always examine the hip joint, rotational movement, especially internal rotation of the movement. And one more thing, when you examine this, one should not forget to the deep tendon reflexes. So, and Babinski sign, all these things one should do thoroughly. And distal neurovascular, of course, vascularity pulse is more important. In my clinical practice, most of the time I found that when you flex the hip or knee and see all rotations and SA joint is normal, and especially superior lateral aspect of the cuff and 90 hip or 90 knee, if you give deep tendon, deep pressure, most of the spinal pathology will have the severe tenderness in that area. When you squeeze the cuff, they will run along the cuff downwards. That what we call it as recent signs of the crying of the dying nerves. Most of the time it happens. 99% of the spinal pathology, they will have these signs. Of course, I think most of the literature is not highlighted. When you have the red flag signs is there is no doubt we are going to operate the spine. When you have doubt, with whether in the hip or in the knee, always you go for, in my practice, ENMG should be done and add on with the spinal injections, and nerve root block can be done before taking for any major surgical. So that will differentiate between whether you have to operate the spine first or you have to go with the replacement first. And always, as Ram said, in my all practice, in the highs do whole spine screening along with the SA joint. When a clinical examiner says something wrong in the hip, to screen the hip also, along with DMD in all the cases. It's my routine practice, and I believe in any operating surgeon should examine the case once and he has to satisfy clinically before putting the knife. Once somebody is screened, somebody is operating, it never work. I won't never believe in that. When you examine clinically thoroughly, your clinical signs correlating with the MRI, whatever imaging, then only you are believe in operating. Somewhere is not matching, I will not operate the spine. I'll wait and look for something else is wrong in this patient. I won't mind and discussing the cases as my clinic audit is there with my colleagues and neurologists and others. That's what I believe in that. And ENMG and root blocks plays a major role in differentiating from primarily from the spine or from the distal. I think most of the aspects are covered by our seniors. I think there is no substitute for thorough history and clinical examination. First, the clinician should conclude himself before getting the image, where is the problem. Then after your clinical diagnosis only, try looking the imaging system. Then you are 100% right. If you first you see the image and try to operate, most of the time we are wrong. That's what my belief.
Thank you, sir. Thank you. And so the clinical examination is the key point. Now, may I ask Dr. Mahesh Prasad, member of this IOA Spine Subcommittee, to say few words on today's topic.
Sir, unmute yourself. Unmute yourself.
Sir, please unmute.
Thank you, Partha, and I show all the meeting for different faculty and the decision making of this area of knee replacement and a spine surgery is a very difficult. Which one go first? That depending upon their history or a clinical examination. The problem is when the symptom of spine is become a tie, the equal situation. What will be the go first thing for the spinal surgeon or the knee surgeon? If the patient goes to the orthopedic side, knee should be the first. But in the cases of a spine surgeon, my stake is what should be the first. If the condition between two is very difficult to decide whether go towards the spine or the knee situation. I want to explore from the Chaddha sir, what is the situation is to proceed first, either spine or the knee.
Sir, if both are identical, patient needs both. clinically and radiologically, but patient does not have cauda equina syndrome, I would let them take the knee first.
Yeah. Yeah. Apart from the cauda equina syndrome, certain other condition in the spine like neuro, difficult to decide whether it is due to a long-standing diabetes or whether it is due. How can you differentiate these symptoms?
The electrophysiological testing, EMG nerve conduction,
EMG,
CP
yes.
on one side, endocrine evaluation on the second side, a bone density check on the third side, correct everything first, review the patient, look for vitamin B12 deficiency. All these things have to be looked for and then optimize your patient. If there's no cauda equina, do not be in a hurry to operate the spine.
Sir, just one question.
Yeah.
Just two questions to Ramchaddha, sir. First, is it only the cauda equina or any neurodeficit of recent onset with spinal stenosis? If the patient comes with a foot drop, say 2/5 power, along with knee osteoarthritis, what is your take on that case? It is not a case of cauda equina, but a recent onset deficit.
Recent onset painful foot drop, I will operate the spine first.
Taken as in cauda equina.
So that word which I mentioned called recent onset painful foot drop.
Yes.
You may have a painless foot drop. In that case, again, the patient moves away from you because your painless foot drop may not recover. So always remember, recent onset painful foot drop is a red flag.
Sir, second question, sir, regarding, we have already had a discussion regarding the installation of the local anesthetic in the knee and also the spinal blocks to differentiate which is more important or which is giving the rise to more clinical symptoms. But the main problem, what I feel, that most of the time with coexisting spinal stenosis, it is not a radicular pain. It's not a, say, slip disc that we can put our needle as for a selective nerve root block. Most of the time, it's a lateral canal stenosis or a central stenosis. In that case, what I feel, it may not be very helpful to do a root block because most of the time it's not a root symptom. Rather,
you have to do epidural steroid in that cases actually, not a root block. Epidural will work in such cases. Definitely symptomatology, they may not improve 100%. They're better off than the before injections. Epidural will work in canal stenosis too, definitely. That will differentiate from the spinal quality or from your knee first.
So today we have discussed a lot regarding this issue. It is a very burning issue. We are facing this two problem very common in our practice. So Dr. Ram Chaddha and Dr. Indrajit Sardar has guided us and give us the algorithm how to manage this kind of patient. So now if I request, the time is just now over. So may I request our advisor of I0A Spine Subcommittee, Dr. Ram Chaddha sir, for his concluding remarks. Before that, I must say thank you to all participants, and I always very big admirer of our Ram Chaddha sir. So he has given us this opportunity. So thank you, sir. Thank you, our President sir, Dr. Atul Srivastava. Thank you, our General Secretary, Dr. Navin Thakkar. Thank you, Indrajit Sardar sir, Dr. Rajiv Chatterjee sir, and Dr. Mahesh Prasad, and Dr. Mallikarjunaswamy, and our Kanchan Bhattacharya, and Dr. Amlan Jyoti Roy, Dr. their contribution of today's talk. So may I request Dr. Ram Chaddha sir to please say a few words to conclude this online.
Thank you very much. It's been a pleasure to be here. And I think we've had a very, very warm yet very specific discussion about what to do where. There may not be clarity and each patient has to be looked at individually. And we have to look at those specific situations where there are confounding issues or outliers, pick them up. As rightly mentioned by Dr. Sardar, there are situations where the knee needs to come first and the spine goes later. And very rightly pointed by Dr. Navin Thakkar that there is the hip and the SI joint at times which are overlooked and which need to be also looked in, because this is the entire same area which gets affected. And look at the patient as a whole. As mentioned by Dr. Mallikarjunaswamy, lumbar canal stenosis coexists at times with a tandem cervical or thoracic stenosis that needs to be looked at as well. And please look at the patient completely. Do not be in a hurry to put the knife on the patient, because these are both elective surgeries. The only place where you have to be in a hurry is where there is a recent onset neurology or a cauda equina for the spine. And as far as the knee is concerned, they are usually elective planned procedures, and the patient needs to buy the operation rather than we sell it to them. So thank you very, very much. I appreciate all the seniors and my colleagues who were here. It's been a very, very fruitful discussion, and we are happy that we could have some agreement where most of us tend to disagree today. Thank you so much.
Thank you.
Thank you, sir.
Thank you, Ram.
Thank you. Bye-bye.
Thank you. Thank you.
Thank you,
sir. Navin, sir, how are you?
And one case from the Dr. Rajiv for metastasis. So metastasis has to be looked in. Great. It was a great discussion. Fantastic.
Thank you, sir.
Thank you, everybody.
Thank you.
Thank you, sir.
Who is living the last?